My pleasure to introduce Dr. Mark R. Chassin. As President and Chief Executive Officer of the Joint Commission, Dr. Chassin oversees the activities of the nation's predominant standard-setting and accrediting body in healthcare. Dr. Chassin is also President of the Joint Commission Center for Transforming Healthcare, which works with the nation's leading hospitals and health systems to address healthcare's most critical safety and quality problems. Previously, Dr. Chassin was the Edmund A. Guggenheim Professor of Health Policy, founding chair of the Department of Health Policy at the Mount Sinai School of Medicine in New York, and Executive Vice President for Excellence in Patient Care at the Mount Sinai Medical Center. Dr. Chassin also served as Commissioner of the New York State Department of Health. He is a board-certified internist and practiced emergency medicine for 12 years. He is also a member of the Institute of Medicine, now the National Academy of Medicine, and served on the committee that wrote the landmark reports To Air is Human and Crossing the Quality Chasm. Dr. Chassin received his undergraduate and medical degrees from Harvard University. He holds a master's degree in public policy from the Kennedy School of Government at Harvard and a master's degree in public health from UCLA. Dr. Chassin, welcome. The floor is now yours.
Thank you very much. I'm delighted to be with you this afternoon to talk about high reliability. And I really have one overarching goal for the presentation this afternoon, and that's to make the case that if we are going to get safety and quality to where we all want it to be, we need to think and act very differently with respect to quality of care. And I'll come back to that theme throughout the presentation. At first, I want to address a question that might be occurring to you, which is, why is the Joint Commission talking to you about something like high reliability? And the reason is that the Joint Commission today is very different from what it used to be. We've had a very strong emphasis in the last several years on dramatically improving our accreditation and certification core processes, enhancing value to our customers. I'll talk about how we've been doing that later on. We've been a very effective advocate for our customers with CMS, getting them to modernize a lot of their outdated conditions of participation. We continue to do that. And we've realized that in order to move the delivery system further and faster, high reliability is a very important and new idea. And finally, we are, in addition to being a wonderful accreditor, my view, we're also now an improvement company, creating and delivering solutions to some of the most difficult quality and safety problems that we've been struggling with for so long, and I'll share some of those new tools with you a little later on. And finally, this is a little summary of all of our customers in the United States. We are the only accreditor that operates across the entire continuum of care. And in most recent years, we've focused on moving away from doing that business only in silos, the way the healthcare delivery system is organized, and recognizing that more and more consolidation is occurring across the delivery system. We've created a number of different tools and programs and activities that help our customers not only put pieces of the delivery system together, but make sure that they're working together in integrated care certification programs and activities to reduce handoff communication failures, and I'll address a couple of those as we move forward also. So the reason that I've focused on how we need to think and act differently with respect to quality is that despite the fact that we've put an enormous effort into improvement over the last 15, 18 years, certainly since the IOM reports, we've made some progress, but we still have incidents like this. This fellow doesn't look too happy. He's not happy. He is holding an insulin pen. He's the CEO of a hospital in Connecticut, and he's holding a press conference together with his physician leads in gastroenterology and infectious disease to explain to his community how it was that more than 3,000 patients over 6 years were exposed to hepatitis B, hepatitis C, and HIV because of the misuse of insulin pens. We set fire to patients in our operating rooms. Operating room fires occur in the United States about 650 times every year. And we still have an inability to eradicate problems like this one, which actually is from the state of Massachusetts earlier this year, where patients get exposed to procedures that were intended for somebody else. Long site surgery and invasive procedures in the United States occur about 40 or 50 times per week. So I think it's fair to say that despite this effort that we've made, and it's been considerable, and I'll talk about some of the progress that we have made, but I think it's fair to say that today we see that routine safety processes fail routinely. These and many others that you're very familiar with do not fail just 5 or 10% of the time. They fail 40, 50, 60% of the time. And that is despite a lot of effort, including Joint Commission National Patient Safety Goals. A lot of improvement effort has dented these problems but hasn't eradicated them. And we are still plagued by this cavalcade of terrible adverse events that no patient or family member should be exposed to. And I think that if you look at how we've been going about improvement, we have made some progress, and I don't want to be misunderstood. That progress has been important and has led to a lot of specific areas of reduction of adverse events, but that progress has tended to be one project after another. And I hear all across the country, including in your state in Massachusetts just last week, that organizations, hospitals, health systems, ambulatory organizations have project fatigue. They just can't take on that next project. And we tend to focus on very specific problems. A project for central line infections, a project for pressure ulcers, a project for managing high-risk medications like chemotherapy. And we tend to be satisfied with modest improvement. If we get 20% better, that's really terrific. But the approach we've been taking isn't good enough to get us to zero. It turns out to be very difficult, and you know this very well, very difficult to get to high levels of safety, to sustain that safety over long periods of time, and even more difficult to spread what works well in one place to another place in your hospital or in your system. High reliability offers a very different approach. The first reason it's different is that the goal of high reliability is much more ambitious. The goal is to get to zero. Zero harm to patients, zero harm to caregivers, and broaden your thinking about what zero harm means. It certainly does mean getting rid of complications, but the patient safety movement, I think, has tended often to focus us too narrowly only on complications. Zero harm also means no episodes where we fail to deliver effective care when it would have produced a good outcome. No episodes of the delivery of care when there is no benefit, antibiotics for colds, imaging, and simple back pain. So think about zero harm as a much broader goal than simply getting rid of complications, which is difficult enough. The second reason that high reliability is different is it's not a project. High reliability organizations, those organizations that operate in very hazardous circumstances but have succeeded in creating superlative safety records over long periods of time, whether it's commercial aviation, nuclear power, or even large-scale amusement parks, those organizations don't stay safe by having 150 projects going on at every point in time. They stay safe because zero harm is the natural byproduct of the way they do their work every day. And that's the transformational goal that high reliability is aiming to produce in healthcare. Zero harm to patients, zero harm to caregivers, the natural byproduct of the way we take care of patients every day. The Joint Commission, we've had a team here working with academics, with experts from practitioners from high reliability organizations, and these and many other industries across the country, indeed around the world, understanding what's known about how these organizations work. And we've married that knowledge with what we know as the Joint Commission about where healthcare fails. We survey organizations about 13,000 times a year, and we've seen every variety of healthcare organization, that long list that I showed you, across the continuum of care across the country, and all of the quality problems that exist. And what we concluded very early on in this work is that you can't simply take how aviation or nuclear power stay safe and prescribe that for healthcare. Healthcare is in a very different situation than these industries. These industries do not have safety procedures that fail 50% of the time. So we've married what we've learned from high reliability organizations with what we know from our work with healthcare organizations to create a model for how healthcare can start down the road to high reliability. And there are three major domains of change that healthcare needs to work on. First is the leadership of healthcare organizations need to be committed to the goal of zero harm. Second is a safety culture that is imbued throughout high reliability organizations we need to adopt in healthcare organizations from top to bottom. And the third domain of change is that we need to adopt much more effective process improvement tools and approaches, what we call here at the Joint Commission robust process improvement, Lean, Six Sigma, change management. And I'll talk briefly about each of these in the next few minutes. One of the hallmarks of a high reliability organization is that everyone who works in one of these organizations essentially has two jobs: the job they were hired for and improving processes that they touch inside that organization. That's what we need to get healthcare organizations to be able to do, where everyone recognizes that their second job is quality, safety, protecting patients, and helping the organization get to zero. We have lots of new tools, resources, and programs, and I'll point you to how to get to those in a minute. This is an article that my colleague and I, Jared Loeb at the Joint Commission, wrote a few years ago that lays this high reliability framework out in great detail. It's still a very relevant piece of work, and I'll show you how to find that also in a moment. We have a very rich high reliability resource center at the Center for Transforming Healthcare's website. We have a self-assessment tool for hospitals that has been extensively tested, that is available now to all accredited organizations, no added cost as part of accreditation. You can dial into it. I'll show you how to find that as well. What this tool does is lead your leadership team through a series of questions that will profile where your hospital is on 14 different components of high reliability in 4 different stages of maturity. It's a great diagnostic vehicle to show you where your strengths are, where you need to focus if you really are determined to get to high reliability. We are partnering now with state hospital associations in these and other states. In South Carolina, we've been working with the State Hospital Association for 4 years to help their hospitals work through first the self-assessment tool, identify where they are strong, where they might have mutually reinforcing programs that they can share with each other. In Michigan, we're well into the second year. Illinois has just started in a similar vein with groups of hospitals that want to understand where they are on the road to high reliability and make as much progress as rapidly as possible. We've also trained our surveyors to introduce the high reliability framework during surveys with the leadership of hospitals and health systems if the hospital and health system is getting on that journey to high reliability. And we have a lot of tools to help you get to zero in specific quality problem areas that I'll share with you more information about in a few minutes. So I said high reliability is gaining momentum, catching on. One of the ways to notice that is just Google high reliability, and what you'll see is about 10 million results. The first result is that paper that I mentioned, published in Milbank, that lays out our high reliability healthcare framework. And the second hit is the web page on the Joint Commission Center for Transforming Healthcare's website that links you both to Oro, the self-assessment tool, and to the Resource Center. So you don't really even have to know how to get to the Joint Commission's website. Just Google high reliability, 2 clicks, and you're there with lots of resources at your disposal. So I said 3 major domains of change, and let me talk briefly about each one. What do we mean by a leadership that's committed to the goal of zero harm? Well, actually, leadership means what our accreditation manuals say it means. It means that all of the components of leadership, from the governing body through the CEO and his or her management team, physician leaders, nurse leaders, both formal and informal leaders, need to be aligned around achieving the goal of zero harm. And that is a big leap for many in healthcare. But the reality is that we're not suggesting that you can get to zero tomorrow, but when you commit to getting to the ultimate goal of zero, lots of things start to change about how you approach safety and quality. Quality, first, becomes the number 1 strategic priority of the organization. Not one of 5 or 6, but the number 1 priority, and there's only one number 1 strategic priority. Physicians lead and participate in improvement throughout the organization, and your quality program goes beyond the requirements of outside organizations, whether it's CMS, state organizations, payers, the Joint Commission. You know your patients better than anyone else, and there are lots of excellent metrics and improvement tools that can be directed at the most important risks that your patients face, the most important quality problems they face. That's where your quality program should be directed. Now, it takes a lot of education and a lot of courage to ignore all of the loud voices from Leapfrog to Health Grades to Truven and all the others that rate hospitals on various what they call measures of quality. But it turns out that between 95 and 100% of the metrics in those programs are demonstrably invalid measures of quality. So don't be distracted by those measures. Educate your board and your leadership on just how invalid they are, and we'll be happy to help you compile that information. Because what you need to be focused on is your patients and what's going to make improvement worthwhile for your patients. And when you get those measures and you start working on measures that matter to your patients, publish them. Circulate them inside the organization. Publish them to your community so you can demonstrate how you are improving on quality problems that matter to your community. Once you get the leadership commitment rolling, one of the most important areas to tackle is safety culture. We've heard often that what healthcare needs is a blame-free culture. Well, that's almost it, but not quite. High reliability organizations don't have blame-free cultures. They have cultures that identify blameless errors, and those are errors in healthcare that typically are made because we put very well-trained and well-meaning caregivers in broken processes where it's very difficult to consistently do the right thing. The errors that are made in those situations we need to have reported. Those need to be treated with a blame-free approach because they point directly to the weaknesses in our safety systems that we need to understand so we can fix them and strengthen them for improvement going forward. But at the same time, high reliability organizations know and have processes to deal with blameworthy acts, with patterns of behavior and errors that are reckless and that need to be referred to disciplinary processes. In healthcare, we have 2 major impediments to making serious progress toward that kind of safety culture. The first is the challenge that the ubiquitous, intimidating, and disrespectful behaviors that healthcare workers are exposed to all the time, the risks that they pose. And the second is our inability to hold everyone accountable with disciplinary action if necessary for consistent adherence to all the safety practices and protocols that your organization has. High reliability organizations have figured out how to balance learning from blameless errors and holding everyone accountable for consistent adherence to all of the safety protocols that keep their organizations safe. Now, if you ask what kinds of behaviors are intimidating, it turns out there's an incredible range of these behaviors, from impatience to literally to physical abuse, shoving and other kinds of physical abuse, which fortunately we've measured, others have measured, and it's very rare. But if you ask what are the most common behaviors that healthcare workers experience as disrespectful or intimidating, these are the ones that are always reported. Refusing to answer questions or return phone calls or pages. A condescending tone. That's a really dumb question. I don't need to be bothered with that one. Now, 2013, the Institute for Safe Medication Practices published a survey in which 11 to 15% of the folks who responded, almost 5,000, said they had personally experienced these most common disrespectful behaviors from physicians and non-physicians more than 10 times in the past year. And this survey is a real trove of information about the kinds of behaviors that we're talking about here. 63% said they were exposed to constant nitpicking and fault-finding when there were no problems and no serious errors. Now, the Joint Commission wrote about this 8 years ago now in a Sentinel Event Alert that is still very relevant, titled Behaviors That Undermine a Culture of Safety. And when we started talking about these behaviors and started putting safety culture requirements in our leadership standards, the healthcare media and a lot of healthcare organizations took this message and oversimplified it and made it a problem of disruptive physicians. Now, that's a really bad error because it misleads us in two different ways. It first of all misleads us into thinking that this is a problem only of physicians, when that's not the case. And it misleads us into thinking about the types of behaviors that we need to focus on in disruptive. The caricature, of course, is the surgeon having a tantrum in the operating room and throwing instruments, which is really bad behavior. But that's pretty rare, and I've shown you some of the behaviors that are much more common that we need to be concerned about. And I'm sure there's some nurses in the audience today, and you're very familiar with this phenomenon that nurses refer to as nurses eating their young, to make the point that it's not only physicians that engage in the kinds of behaviors that we need to be concerned about. Now, the Institute for Safe Medication Practices, in addition to publishing this survey on the kinds of behaviors that are perceived as intimidating and disrespectful, also published some critical information on another important aspect of this problem. And that is that while some might think that impatience with questions and condescending tone are unpleasant exposures to healthcare workers that make the workplace a kind of unpleasant place to be, but don't we really have other more pressing safety and quality problems? Well, I would argue no, we don't, because exposure to those behaviors encourages a whole range of unsafe practices. And these are some of them that the Institute for Safe Medication Practices asked about. Did you ever assume a medication order was correct because you didn't want to talk to that doc because he yelled at you the last time you had a question? Did you ever ask somebody else to talk to that doc because she was rude and didn't take your question seriously, et cetera? 2,100 folks answered these questions in 2003. And the percentage who said yes really should be zero. If we're a high reliability organization, these percentages should be zero, and they were not in 2003. The other interesting feature of this survey is that they repeated it a decade later when almost 5,000 folks answered these questions, and the progress we've made in that decade is pretty small. They asked two bottom line questions. They asked, has your own personal experience with disrespectful behavior changed what you do when you have a serious safety question about a medication order? In 2003, 49% said yes. In 2013, not many fewer. And the bottom line, perhaps the most important bottom line question for healthcare leaders is this one. They asked folks to agree or disagree with this statement. My organization deals effectively with disrespectful behavior. In 2003, 61% said no. 56% said no a decade later. And I would argue if you don't have, as an important part of your quality improvement program, a program that focuses on getting rid of disrespectful behavior, you are missing a huge opportunity to reduce risk in your organization. Is it any wonder that we still have so many medication errors given this problem? You can't get rid of it if you don't know how often it occurs. And it's easy to measure. You can adapt questions from the Institute for Safe Medication Practices survey, which is called the Workplace Intimidation Survey. Do you have a code of conduct that is specifically focused on eliminating intimidating and disrespectful behavior? In fact, we have a leadership standard that requires you to have one. It's not enough to have one. You have to have clear definitions on what are acceptable and unacceptable behaviors and calibrated enforcement mechanisms leading to disciplinary action if you have serial violators of safety protocols or of the code of conduct. The disciplinary procedures ought to be clear and transparent and equitably applied across your organization so that everybody knows it's the behaviors that are important to eliminate if they're unacceptable, and not focus on specific individuals or types of individuals. These criteria and processes need to be applied across the board. So that's a quick overview of safety culture. Let me turn to robust process improvement. This is nothing mysterious. Robust process improvement is simply a group of 3 sets of tools that together represent a much more effective and much more systematic approach to problem solving than we have ever seen applied to clinical quality and safety problems: Lean, Six Sigma, and change management. And I would just digress for half a minute and say that we inside the Joint Commission have fully adopted all of these tools. We are training our entire workforce. We're up to about 60%. We will keep going until everyone is trained. This is the mechanism by which we have been able to improve our survey processes, our accreditation and certification programs, increasing value to our customers. We measure this extremely extensively across the organization. And I know from talking to many of you in Massachusetts, I've been there now 3 times in the last 6 weeks or so, that many of your organizations are seeing the result of that work. RPI has had a huge impact on making that happen inside the Joint Commission. We're also adopting all the components of safety culture, walking the walk that we are suggesting that healthcare organizations take, and we measure how well we're doing in deploying RPI and achieving safety culture, and those 2 metrics are on the very short list of 12 or so measures that we report to our board as part of our strategic plan. Our board sets targets for us, just like they do for financial performance, for customer satisfaction, employee engagement. These are measurable initiatives, and our board is pushing us forward in that spirit. Let me take just another couple minutes and talk about each of the 3 components of RPI: Lean, Six Sigma, and change management. Lean has a philosophy and a set of tools. The philosophy is perfectly aligned with high reliability because it teaches employees to identify and act on opportunities that they see every day in the processes that they touch for improvement. Typically in high reliability organizations, unsafe conditions are identified way upstream, way before they mushroom and cause harm or even pose any risk to the organization, when they're easy to fix. Employee empowerment is a key part of Lean. The tools in Lean increase value by eliminating steps and processes that are completely wasted effort. When you watch a nurse going from place to place on an inpatient unit to collect all the things that he needs to change a surgical dressing, and he has to go to 5 or 6 different places. All of that bouncing around is wasted effort, time that could be repurposed for bedside patient care. And Lean helps you find those wasted efforts and get rid of them. Six Sigma improves the outcomes of processes, and that is a vital part of process improvement. Lean makes processes more efficient. Six Sigma improves their outcomes. Six Sigma also gives us a way of thinking about and measuring our way to zero, because Six Sigma measures bad outcomes in defects per million opportunities. We're used to thinking about improvement and processes in healthcare in percentage terms. So if a process goes right 99% of the time, we feel pretty good about it. But a 1% failure rate in Six Sigma land would be 10,000 defects per million. So if you're working to get a bad process down to zero, Six Sigma has the language and the way of measuring in addition to the tools to get us there. Together, those two sets of tools are the most effective ways to improve processes that we have ever seen in healthcare. And together, they routinely produce 50% or more improvement with one effort. And I'll show you some examples of that a little bit later on. And that gets us to where we need to be with respect to improvement tools, because if we're at 50% hand hygiene compliance, we shouldn't be happy to get to 55 or 60. We need to get to 90% and keep going, and I'll show you some examples of that. Lean and Six Sigma produce the improved processes at this very high rate of quantum level improvement that we need in safety and quality. But Lean and Six Sigma provide the technical solutions to how to make processes work better. And the technical solution by itself is not enough for an organization to realize the benefit of all of that improvement work. Jack Welch, when he was at GE rolling out these tools, encountered a lot of success, but he saw a fair amount of failure. And he asked this question: why do efforts using Lean and Six Sigma, and other improvement tools for that matter, fail so often? The answer came back from a group of consultants that was very counterintuitive. What they found was 90% of the failures that they examined had a pretty good technical solution to the problem they were trying to solve. They failed typically because the organization didn't accept and implement the solution that it had. Now, that most typically happens when an organization turns a process problem over to a group of experts. They go off in a conference room and collect data and solve the problem and hand the new process back to the people that have to implement it without involving them at all, and turn the whole organization off despite the fact that the solution is pretty good. RPI, with the third set of critical tools, addresses this challenge directly by employing change management, which is a systematic way to get the organization ready to accept and implement the newly improved processes that are coming out of the Lean and Six Sigma work. And in my experience with about 20 years using all of these tools, it is the change management component of RPI that is in fact the rocket science of improvement. And let me just give you a brief overview of what we use at the Joint Commission called facilitating change. And the first and probably most obvious step is make sure at the very beginning of any improvement effort that you engage all of the stakeholders. Figure out who is going to own this newly improved process, work with them throughout the improvement process so that they are the experts in the new process and can deploy it. Paint a very inspiring picture of why we need to tackle this problem, how much better off we will be, our patients will be, when we solve the problem that we're directing this improvement effort at. In launching the initiative, make sure that communication to all stakeholders about what the change is going to involve, how their roles will change, what they need to do, how they can be helpful. And then as you get past the initial deployment of the intervention, pay very close attention to how the improvement will be sustained, empowering the process owner who's been engaged so that you essentially hand that individual an owner's manual for the new process that shows them how to continue the measurement to make sure that performance continues at the high level you've achieved with the intervention, and what to do when the process starts to slip back to the way it was before, which virtually always happens, in order to catch that slippage before it becomes too bad and correct it. And recognize that change management is not linear. That is, you have to pay attention to all of these components of managing change throughout the process. You have to, in fact, start the process with an eye toward how you sustain the improvement that will be realized by the proper deployment of Lean and Six Sigma. Let me give you just one quick tool to illustrate that this is not just touchy-feely stuff, that these are teachable tools that will help you manage change throughout your organization. I said one of the most important first steps is to identify and engage all of the relevant stakeholders in a particular project area. Recognize that getting all of them to talk about a problem that they have in common is a very important part of improving safety culture, but it's not enough just to identify them. You have to identify what role they play in the particular improvement effort that you're undertaking. And we use something called an Army analysis in order to do this. Some of the stakeholders, one or two typically, will be approvers. You will need to get their approval and sign off, and they occupy a very particular and important role in your improvement effort. Some will be important resources. So if there's a local expert in the area in medication management or infection control, you must make sure you involve that person, otherwise you'll lose credibility in your local environment. Some stakeholders will be great members of your team. They'll do the work. They have subject matter expertise in the process that you're engaged in improving. And others may not be approvers or play any of these other roles, but they'll be very interested parties. And if you don't pay attention to them, they may turn into resistors if they're not engaged and kept informed. And keep in mind, especially in a longer project, that roles can change. So you have to revisit this analysis periodically throughout the change process. And this is just one of many tools that are teachable. We train change leaders at the Joint Commission, and they are one of our most important engines of changing daily work. Today, unfortunately, even though there are an increasing number of hospitals and systems that are starting to use these tools, when you encounter one program, you don't know much about the next one you're going to see because they're used very differently. And most only use some of the parts, typically Lean or maybe Lean Six Sigma. And most unfortunately, the change management set of tools is the one that's most often left out. And typically, we've seen this over and over again when an organization leaves out the change management tools. Sooner or later, the Lean Six Sigma program hits a speed bump, doesn't work, and then it's too easy to throw the tools out, blame the tools, when the organization could have had success by including change management. Transforming an organization to high reliability requires getting past the more typical notion that these tools are best used by training a small group of experts and then parachuting them in to solve a problem. The organizations that have used these tools in business have used it to transform by training everyone. And that's what we need to do in healthcare. And it turns out that there is, in addition to all of this, a tremendously compelling business case for adopting RPI, because the administrative processes that we struggle with in billing, supply chain, throughput, revenue cycle are often just as broken as the clinical processes that we struggle with on the quality and clinical quality side. RPI can directly improve margins by fixing those processes. And in fact, when I was doing this at Mount Sinai, one of the most important, powerful arguments to my CEO was that we were able to reduce, not quite eliminate, but almost eliminate, the need for hiring niche consultants in all of these areas because the RPI teams could solve these process problems as well. And that effort can produce a positive return on the investment that you need to make in adopting these tools. The MAHQ program has demonstrated, and you'll have this in your handout, this reference if you want to see it, their return on investment for their program is 5-to-1, conservatively scored by their finance department. An example, when I was at Mount Sinai, one of the most important service lines was invasive cardiology. There were stories about ineffective billing for all of these devices, and it turned out to be a very complex process involving the faculty practice in cardiology, the cath lab, nursing, all of these stakeholders. Never had they gotten around a table to focus on the problem. When we used RPI, we discovered there was a 63% error rate in the bills for these procedures. Some $50,000 implantable defibrillators were being billed out as $2,000 pacemakers, and vice versa, by the way. So there were a lot of problems in this process. The RPI project took that error rate down from 63 to 5.6%, dropped $5 million to the bottom line directly. Another project in chemotherapy billing similarly dropped $1.7 million to the bottom line. Those two projects by themselves, paid for the entire program over 6 years with a return on investment of 4-to-1. We have now a large group of experts in Lean and Six Sigma change management at the Joint Commission. We've studied, as I mentioned, how a group of major corporations have deployed these tools to great effect. We have a lot of experience in clinical quality and safety with our Center for Transforming Healthcare, applying RPI, which I'll close with in a minute or two. And we are now in the business of training hospitals and systems if they want to transform to high reliability. We are able to produce in those organizations by transferring this technology, embedding RPI throughout the organization, a self-sustaining RPI program with a positive return on investment that can be demonstrably sustained over many, many years. In our Center for Transforming Healthcare, that's been the hub of our effort, working with 27 hospitals and systems that have also mastered RPI to attack the safety and quality problems that have eluded solution for so long. This is a list of the 27 hospitals and systems. You'll see a number of the usual suspects, if you will, from Mayo and Kaiser and Hopkins. But I want to call your attention just for half a second to Wentworth Douglas. Wentworth Douglas is a 170-bed hospital on the seacoast of New Hampshire, just up the road from you all. It's not part of a large system. They have a fabulous RPI program. In fact, their Department of Environmental Services won this award, Department of the Year award, from Health Facilities Management magazine in 2014, and they won it for this accomplishment. In 2012, the hospital added a new wing, an ambulatory wing with 130,000 square feet of space that needed to be cleaned. The CEO, Greg Walker, went to the staff and leadership of the Environmental Services Department and said, I want you to add this new building to your existing workload, but you can't hire anybody else. You can't use any temporary workers, no overtime, and you have to maintain the extremely high quality of the cleaning that you do because it's so vital to patient safety. And they used RPI, both the trained folks who were trained inside the department and the experts within the hospital, to redesign their workflow, and they met that challenge, saving the hospital over $400,000. And their program, despite the fact that it's a small hospital, has consistently documented a return on investment of 3-to-1, and only 60% of their projects aim at producing financial gain by tackling problems like this. But you don't have to be a Mayo or a Hopkins to have an effective RPI program. When we've used RPI, we have found that one of the other problems with the way we've been going about improvement is that we have tended to do a one-size-fits-all best practice approach. Here's the way to do pressure ulcer prevention. Here's the way to do central line infection prevention. And it turns out that complicated processes require much more sophisticated problem-solving methods. And what we find consistently is these three things. If you don't remember anything else, burn this into your mind, because this is one of the hearts of why we have not made more progress. It turns out that there aren't just 3 or 4 reasons why people don't wash their hands or risks of wrong site surgery. There are 20, 30, 40 different reasons. Each one of those requires a different strategy to eradicate. But we don't find all 20 or 30 with equal frequency whenever you look at one particular location. You typically find 5 or 6 that explain 70 or 80% of the reason you have the problem. So you can devise a very targeted, very tight set of interventions to get rid of your causes and have a great effect. But the rub is that when you take that same set of interventions to the next place, the next unit, the next hospital in your system, you don't get the same results because the key causes differ from place to place. RPI is producing the next generation of best practices, solutions that are customized to the reasons you have the problem, not somebody else's reasons. One quick example of this comes from our work in hand hygiene compliance. Here are 5 of the top 20 reasons why people don't wash their hands in hospitals. Each one of them requires a different strategy to eliminate, so that's points 1 and point 2. If you look at number 5 there, that's the safety culture relationship to hand hygiene. You can have all the hand gel dispensers in the right places, have them always full and all ready to go, but if you don't have a safety culture that obligates everyone on that unit to stop somebody from going past that hand gel dispenser without cleaning their hands, you don't have a good hand hygiene program, and that requires, again, a very different strategy than all the rest of these to get rid of. And here's the third point, that key causes vary. Each row in this table is one of the top 10 causes of hand hygiene noncompliance. Each letter, each column represents the data from one of the original 8 hospitals that was in this project with us. An X in the box means that that cause was proven statistically by the quantitative side of RPI to be one of the key causes at that hospital. The key causes vary from place to place. Now, if we had said, you know, sorry folks, this is not just a 3 or 4 step best practice, it's a 10-step best practice. When we had uncovered the top 10 reasons, you really need to have a program that gets rid of all of these causes. Hospital A would have been wasting its time with interventions directed at the causes in the red circles there because they didn't have those problems. So the point here is that not only is this approach, the RPI approach to problem solving, highly effective because it precisely identifies the causes you need to pay attention to, it's also very efficient because it prevents you from wasting time on problems that you don't have. And as I said, when we apply these tools to solving these very difficult problems, you don't get 5 or 10 or 15% better. You get 40, 50, 60, 70% better because these tools are so effective at identifying the critical causes of the problems and allowing you to focus on targeted solutions to get rid of them. And, by the way, that's what we call the tools that we've made available to all accredited organizations. We call them the Targeted Solutions Tools. We have taken the generalized learning from the projects that the center has created and put them into web-based tools that you have access to as part of accreditation. There's no added cost. The data are all confidential. They don't go to our surveyors. And they walk you through, without the need for being a Lean Six Sigma black belt or a Lean Sensei or any of those specialized training programs. They just walk you through how to measure, how to figure out what your causes are, and download very effective interventions that work on the causes that you have to get rid of these problems. And these are the 4 tools you have available to you right now, including most recently last year, the Falls TST, which the project demonstrated you can get rid of falls. You can reduce falls on average by 62%, falls with injury, with dramatic effects on safety and cost reduction. We are also committed to publishing rigorously the results of these projects. These are some publications of the hand hygiene work. The first 3 years, the TST was used by hundreds of hospitals to get from about 55 to about 85% hand hygiene compliance. That leads to a reduction across the board in HAIs by about 35%. If you're a 200-bed hospital and you get that result, you would save 129 patients from suffering in HAI, save 8 lives, avoid about $2.5 million in cost. Some of that you might save, some of that might go elsewhere, depending on how you're getting paid, of course. But if you're larger, the impact is just that much bigger. But now let me tie this back as I close to high reliability. 85% is pretty good, but that's 150,000 defects per million opportunities to clean hands. When you do better, when you get over 95%, something quite different seems to happen. This is Cleveland Metro Health that got over 95% using the TST. Their bloodstream infection rate fell not by 35%, but by 67%. Here's another hospital that was mired in the 40% range for hand hygiene compliance, used the TST to get up over 90% and stay there for 3 years. Their MRSA rate fell by 2/3. And now let me bring this fully back to high reliability by closing with a story about Memorial Hermann. Memorial Hermann is a 12-hospital system in Houston. They have been on the high reliability journey for about a decade. Back in 2006, they had experienced a series of very nasty and some fatal mismatched transfusion reactions. They got the leadership commitment to get to zero. They started safety culture training, and they have a terrific RPI program. We published the results earlier this year of their work in hand hygiene. One of their hospitals was one of those in the first cohort of hospitals that participated with us in the hand hygiene project of the center. When they saw the results from using RPI on hand hygiene in that hospital, they said as soon as the TST is available, we are going to use it to roll out through our entire 12-hospital system 150 inpatient units. And what I'm going to show you is something called a box plot that shows the result of that work. This little box, when you see the chart behind it, will show you each box is 1 month of hand hygiene compliance data across the 11 hospitals that were remaining in the system that weren't in the original project. The line in the middle of that box is the 50th percentile, the median performance across those 11 hospitals. The top of the box is the 75th percentile, and the extreme high and low values are at the top and bottom of those lines. When they started, the median was 58% hand hygiene compliance across those 11 hospitals. Look at how variable among those hospitals each of those boxes the variability represents. They used the TST to download the tools to figure out exactly what their causes were on all 150 inpatient units. Hand hygiene rates started to improve, and then when they fully deployed the interventions, they sustained improvement at the 96% level through 2014, and now going beyond that to 2016. And look at how they eliminated variation. Huge quantum improvements across the board in hand hygiene compliance, sustained high levels of improvement, and the elimination of variation. This is what you want virtually any large-scale improvement effort to look like. And then they started to see dramatic effects on HAIs. This is one of them. This is their entire system, all adult ICUs, 12 hospitals, ventilator-associated pneumonia at the beginning. Before they adopted the high reliability approach, high and variable rates, they used the one-size-fits-all bundle and got a pretty good level of improvement. But before they deployed the TST, that improvement had stopped. They deployed the TST to improve hand hygiene, and they got to zero ventilator-associated pneumonia across their entire system. This is the scorecard that they use to record the number of HAIs across every category: device-related HAIs, surgical site infection, multiple drug-resistant organisms. For 1 month, this is for one of their hospitals, the Sugar Land Hospital. When they got to 96% and stayed there, they started to see scorecards like this, all zeros across the board. The Sugar Land Hospital, parenthetically, just won the Malcolm Baldrige Award earlier this year. Then it happened again at another hospital, and then again and again. And pretty soon they started to see zeros for an entire calendar year in multiple HAI categories. Michael Shabbat has said, we fully attribute to the Center for Transforming Healthcare's hand hygiene TST the final drop in HAI rates to zero or near zero system-wide. After implementing the hand hygiene TST, our hospitals began to report zeros as their most common monthly central line infection and ventilator-associated pneumonia result. Zero, not some 22nd century fantasy, but zero achievable today using tools and a high reliability approach to healthcare. Our mothers were right after all. Feel free to quote me. This actually saves lives. So I hope I've been able to make the case that we need to think differently, act differently if we're going to get to zero harm, and high reliability offers a framework for thinking like that and for acting like that. The way we've been going about improvement is not sufficient and is not getting us there. RPI has the capacity and is now starting to demonstrate that it can get us there. The culture change component is tough. It takes time and persistence, but some hospitals are demonstrating that zero is achievable. And the Joint Commission has a lot of tools. I've shown you a few of them and how to find out more about them. And I hope to see all of you on the road to high reliability very soon. Thank you very much.
The conference has been unmuted.
Just a reminder now, all lines have been unmuted. So, keep that in mind as you have your side conversations. Thank you, Dr. Chassin, so much for taking the time to share with us today your expertise in high reliability. That was very interesting. The phone lines are now open for questions and answers. And just a reminder to everybody to stay connected to the web presentation in order to complete your evaluation. Do we have any questions? Dr. Chassin, you alluded to the safety, the part about the safety culture taking time. We've heard quotes about changing culture takes upwards of a decade. Do you have any thoughts on how to move that along?
Yeah. And the first, and I'll come back to what I said, there first of all has to be a leadership commitment to making culture change a very high priority in this journey. It's almost impossible to change culture from the bottom up or the middle in if the leadership is not committed and doesn't recognize that that commitment means demonstrating themselves by their actions and behaviors what a safe culture is, then it can't happen. So that's an absolute prerequisite. I think the other ingredient to changing culture is the recognition that many workers in healthcare, especially the closer they are to the front line, this is true, if they spend most of their time actually in their daily work in workarounds because the processes that they're in make it hard to do the right thing, they may not even recognize that what they're engaged in is an unsafe practice. So, for example, we know that distractions during the process of medication delivery are a critical risk factor to medication errors. But if a nurse who's putting her medications together doesn't understand that, and the organization hasn't created a quiet, safe place without distractions, she may not even recognize that she's engaged in an unsafe practice. So part of the safety culture journey is educating workers and caregivers about what unsafe practices are, and the recognition that when you start doing that and doing that effectively, what you see is a decline in the measures that you have in place on safety culture, because people start to realize that they're surrounded by unsafe practices when they weren't recognized before. So that's a very common and often repeated discouraging finding, but if you're prepared for it and you're persistent, you can overcome it.
Great. Thank you so much, all.